Good afternoon. I'm Megan Arrett, and I'm excited today to present Dr. Rob Cotes, the Director for Clinical and Research Program for Psychosis at Grady Health System. In addition to his work at Grady, he also focuses in his P-STAR clinic, which focuses on persistent symptoms, treatment, assessment, and recovery of patients prescribed antipsychotic medications. He's also an associate professor at Emory University in the Department of Psychiatry and Behavioral Sciences and serves as a physician expert for SMI advisor. Dr. Cotes will be presenting on how to distinguish a true clozapine non-response before giving up treatment to try other antipsychotic medications. He will discuss factors to consider when looking for response to clozapine titration and share some examples of his titration protocols with us today. Thank you, Dr. Cotes, for being here.
Thank you, Dr.
One more thing I forgot, Rob. Questions go in the chat at the end. We'll try if we have time.
Great. So delighted to be here. Thanks so much, Dr. Arrett, for that introduction. I'm going to start off with a quick joke. So I was developing this presentation last night, and I noticed that my system had like a critical error and all my work was lost. And as I was racing to sort of ask ChatGPT what was happening, I realized that the entire system had crashed and I could not access ChatGPT or Bard. So that tells you how far we've come over the last, couple of months, sort of relying on these sort of things. Nothing in this talk has anything to do with ChatGPT or Bard, I can promise you. All right. So there is a picture of me. I am a clinician, researcher, and educator, and I work with patients all the time on clozapine. We have access to the Saladex MyCare assay, and I'm going to talk a little bit about how it's sort of changed our practices. Here are my disclosures: research funding to institution from Otsuka, Roche, Alkermes, and Karuna, speaker for clinical care options, and I'm a consultant to Saladex Biomedical and the American Psychiatric Association. So what we're going to do today is we're going to talk about a hypothetical patient, and we're going to talk about how to think about titrating this individual on clozapine and how to use therapeutic drug monitoring to do that. First, we're going to start out with sort of some patient selection issues, then some factors to consider prior to clozapine initiation. We're going to talk a little bit about the titration planning phase, what I like to call, and then we're going to talk about considerations during the titration. So here is a hypothetical clinical scenario. We're working with a 40-year-old male. He's a 1 pack per day smoker. He weighs 80 kilograms, and he's on haloperidol 5 milligrams in the morning and 10 milligrams at bedtime. He's failed aripiprazole up to 20 milligrams and risperidone up to 6. And right now he's talking about having persistent auditory hallucinations. His adherence has been good, and he's been on the haloperidol for 4 months. Okay, so when do we use clozapine? Just a quick review. Here are the 3 times that the APA guidelines for the treatment of patients with schizophrenia either recommends or suggests using clozapine. And we are going to be talking about number 1, the FDA indication number 1, clozapine after minimal or no response to 2 trials of antipsychotic medication. Just so you know about what to expect, it turns out that between 40 to 50% of people with TRS respond to clozapine, and you could expect kind of a mean reduction in PANSS for about 22 points. And this is important, I think, as we think about a framework for how to evaluate treatment response to clozapine versus those who don't respond. Of course, don't forget about clozapine's other indication for the treatment of suicidal behavior for people with schizophrenia or schizoaffective disorder, and then also aggressive behavior as a suggestion. So the predictors of good clozapine response, I wanted to just highlight one of them. And this has to do with identifying clozapine candidates early on. Fewer antipsychotics and fewer psychiatric hospitalizations has been again and again associated with good clozapine response. And then there was an interesting prospective study looking at individuals who were started on clozapine, and then they calculated the delay in initiating clozapine after the onset of TRS. and they looked at a delay of less than 2.8 years and then a delay of greater than 2.8 years. And the difference in response is stark. So in those who were started relatively early, the response was 81.6%. In those who were started a little later, 30.8%. So with this particular person, now that we've decided to start clozapine, there's a couple of factors to kind of consider before you start clozapine. And this isn't an exhaustive list, but age, sex, smoking status, concomitant medications, and also comorbid medical conditions, race, ethnicity, clinical urgency, and metabolism. We're not going to be getting to all of these things today. But again, look, with our patient, this is the variables. We don't have any information about this patient's kind of current kinetic status. Like there was no genomic testing that we had prior to this, sort of hypothetically. So we don't know anything about that. But I just did want to review very quickly a little bit about clozapine pharmacokinetics. Clozapine is broken down into norclozapine. It's primary active metabolite by a number of isoenzymes in the CYP system. Predominantly CYP1A2 does the majority of the heavy lifting. So when you're seeing somebody and you're thinking about clozapine for them, you want to think about what are the potential current drug-drug interactions that somebody might be working with. How can you sort of minimize some of those? We all know that the inducers are going to be the aerohydrocarbons, things like omeprazole. The inhibitors are going to be fluvoxamine, ciprofloxacin, and then the moderate inhibitors are going to be oral contraceptors, and then caffeine acts as a substrate rather than an inhibitor. Okay, so just sort of that's to just get us a little bit of a background, an intro. Then when I think about starting somebody on clozapine, I do like this planning phase. And the planning phase incorporates a number of different things. First of all, you want a framework for how you're going to evaluate response. You're going to think through the titration setting. You're going to come up with a clozapine target dose, which is really where we're going to begin the discussion about levels. We're going to talk about a clozapine titration speed, and then when to get the first level. Okay, so first, if this is a presentation on clozapine response and non-response, you have to be able to evaluate that. And there's a number of different things you can consider. You can guess and say somebody's kind of doing better. You can use the scale that's in the back of the DSM-5 TR called the CRD-PSS. You can use an abbreviated version of the PANS. You can use the full PANS, the BPRS. Neither of those are really going to be appropriate for routine clinical use. You can look at a measure of functioning. You can look at somebody's goals, priorities, a recovery scale perhaps. Might be good to do kind of a combination of those kind of things. But the CGI-I and the CGI-S might be a place to start, just as sort of a quick rating scale that you can use, incorporate really pretty easily. If you have access to other things, that's even better. But this is one place to start. It's sort of the CGI-S. Ask the question, considering your total experience with this particular patient population, how mentally ill is the patient at this time? Then there's 7 potential answers. The CGI-I asks, compared to the patient's condition at admission to the project, otherwise prior to medication initiation, what is the level of improvement? And then there's 7 items. And then if this is the first time you're seeing them, obviously you can't do the CGI-I. Okay, so there's a nice correlation between the CGI-I and PANS. And if you're looking at a 1-point change in the CGI-I, minimally improved, that's a 20% reduction in the PANS. Much improved is going to be equivalent to about a 45 to 50% reduction in the PANS. Okay, so now that you have at least some sort of framework for how you're going to evaluate this, you can think about where you're going to do the titration. And sometimes this is just already decided for you. You're either on the inpatient unit or you're an outpatient psychiatrist. You can't just admit somebody for voluntary hospitalization for clozapine use. Okay. There may be some considerations, inpatient versus outpatient. Inpatient might be higher clinical acuity, suicidality, housing instability, difficulties following the titration schedule, maybe failed outpatient attempts. The majority of clozapine in the US is started on the inpatient unit. Here are some considerations for outpatient titrations. It's typically a slower titration. There's an urgent but not immediate need for clozapine, and maybe you have a little bit more time. Okay, now I want to talk a little bit about how to develop a clozapine target dose. And this is really when we start talking about clozapine levels. So here are some key concepts in thinking about clozapine levels. The ASCP AGMP guidelines have a reference range of between 350 to 600 nanograms per mil. Clozapine levels are measured these days in one of two ways, through LCMS-MS, which is usually a send-out test, or the Saladex immunoassay. We are interested in the clozapine level, not the total clozapine level. And the norclozapine level can sometimes be helpful, but we are talking about today clozapine levels. This is a quick comparison between the kind of current method versus the new method. The LCMS-MS technology usually takes between 2 to 5 days to come back. You have to use a little bit more blood. It may be a little bit more expensive. And then the immunoassay, the nice thing is it comes back very quickly. It comes back at the same speed as your CBC. So typically what we like to do is we like to have our patients get the labs in the morning and then maybe do a group. And then when they come and see us in the afternoon, we have a clozapine level that we can do something about right in front of us. And I think that there's a couple of advantages to having to using the immunoassay. Here are some of the ones that we've noticed. First of all, you can make real-time decisions about adjusting the dose. This is important, particularly as you're evaluating response, non-response, maybe non-adherence as well. So if somebody comes back with a low level, you can then decide to do a retitration, and you can discuss that with the patient right there. It's an improved workflow. It's definitely improved my work-life balance a bit. Instead of getting calls, Friday at midnight, levels high, levels low. And then I think we've also found that it's improved coordination and collaboration between patients, prescribers, and then our system in general. So what kind of level are we trying to get at here? There's a recent meta-analysis published in the British Journal of Psychiatry by Dan Siskin and his group, looking at data from 9 studies. And they found the optimal level of benefit for clozapine was 372 nanograms per mil with an interquartile range of 223 to 558. That means 25% needed levels less than 223 and 25% needed levels greater than 558. So just keep in mind, there's a range. Like 350 is not necessarily a magic number, but it is sort of something to think about, something to shoot for. Okay. One of the reasons that levels are so important is because just if you look at male, female, smoking, non-smoking, you're going to have a twofold difference in the clozapine dose that's going to be required. So the CD or concentration dose ratio is concentration divided by dose. This is the just looking at male, female, smoking, non-smoking, and you can see just how wide the gap is. So personalized dosing is very, very important when you're thinking about clozapine titration. Now, what I like to do is use the clozapine dose planner that's available on SMI Advisor to help me get a sense of where are we going with this titration. And I'm going to choose this option. I would like to predict a clozapine dose that's going to give me a level that I determine, 350 maybe, based on these variables we've been talking about. This is free, smiadvisor.org, clozapine dose planner. Here are the variables we're going to input. Obviously, we can't input all of this, but we're going to put in age, sex, smoking status, and then the level we want to get to. So for our patient, here's what we put it in the calculator. The clozapine recommended dose, just as a ballpark, is going to be 528 milligrams. Okay, so that gives us a little bit of a target of where we need to go. Obviously, we're going to adjust as the titration goes. Okay, now we're going to talk about the clozapine titration speed. There is not one standard clozapine titration. There are a lot of different things that you can do. And I would recommend maybe devising a plan, but you can adjust this as you go on. There's a lot of different examples in the literature. But I think there's some compelling evidence that slightly slower may be slightly safer than faster ones. There's examples of ultra rapid ones, but I think that slower titrations mean less myocarditis risk. You can minimize overshoot issues. And then sometimes people, if they develop tolerability issues, they may discontinue the medication early on. That's the last thing you want. So this is a review of 14 different sample clozapine titrations in the literature, including the US package insert. And this is looking at the clozapine target dose at 2 weeks. And you can just see the variability here. US package insert says 300 to 450 milligrams over a 2-week period. And then you can see the other, some of the other options. And I've shaded sort of inpatient versus outpatient as well. And the dark blue is inpatient, generally faster, light blue, outpatient. So let's walk through an inpatient one real quick. Like from the Dutch guideline, for example. This is kind of like what we do at Grady. So we're trying to get to people to about 200 milligrams over 16 days. Gradual increase, 200 milligrams, 16 days. Okay, how about an outpatient one? Here's one from the North Carolina Clozapine Network. But a couple outpatient considerations. First of all, how frequently can you get vitals? How feasible is the titration based on the complexity of what you're asking people to do? What's the feedback mechanism for how the patient can reach you and how you can reach them if something were to happen? And then I like to do just bedtime dosing until proven otherwise. So for our hypothetical patient, again, 40-year-old male, we want to get to 528. This is probably something like what I would do. I would get them to about 150 milligrams over 21 days in this sort of fashion. A little bit each day. There's maybe 2 increases per week, not more than that. So if you then kind of max this out to over 7 weeks, this is kind of what would it look like to get to about 500 milligrams per day. We're going to be increasing by 100 milligrams after we get to day 28. And this will get us approximately to a clozapine level that's around 350. Okay, so the next thing I want to talk about is when to get the first level. There's a number of different ways you can think about this. Maybe you have a certain dose in mind. Maybe you have a certain predicted level in mind. Maybe it's a certain blood draw. In the outpatient setting, you want to kind of think through these things and plan out when you want to get your first blood draw. Also, of course, tolerability issues or suspicion for non-adherence. So hypothetically, maybe we get this at day 21. The predicted level will be about 126. You want to get the level when you would predict there would be some clozapine there. Okay, now some considerations during titration. Labs. Here's some of the initial lab monitoring. We spend a lot of time talking about what labs to get, and these are just on here for your reference, including myocarditis and interstitial nephritis screening. Okay, back to monitoring response. Now, if we take that 7-week plan that I laid out for you, I like to get the CGIS and CGI-I kind of every other week. You can get it every 7 days, but I like to get it about every other week, and this will help you get a sense kind of if somebody is moving in the right direction. Okay, now let's think a little bit more about using TDM to help us evaluate the response. As we talked about, guidelines reference range 350 to 600 nanograms per mil, but the literature clearly documents that some people need levels higher than 600 for adequate response. And some ideas are about getting up to about 1,000 before saying that somebody is technically a non-responder. And there's been some data that's shown that as you continue to increase the level above 600, you can continue to get some benefits in terms of BPRS, particularly for non-responders. At levels over 1,000 nanograms per mil, the risk of ADRs increases. Risk of seizures probably increase. Now, just about some more expectations around clozapine response. I thought it was really nicely laid out in this study where there was 50 individuals with schizophrenia who were started on clozapine. Once people reached the dose in which they responded, the average response time was 7 days. The range was between 2 to 56 days. And then during a follow-up period of 75 weeks, those who didn't respond did not respond over that time period. So there was no evidence of sort of a second response peak. Okay, so during the titration process, clozapine levels can help you think about the other antipsychotic that's on board. So getting back to this case, I like to think about trying to get people to clozapine monotherapy about by the time we have a level of 350, if possible. If they're on other antipsychotic medications, like more than one, I usually like to begin tapering the more antihistaminic or anticholinergic medication first. And then you want to have, again, this sort of plan to be able to discuss with the patient if there's breakthrough symptoms during this process. So back to our hypothetical titration. This person was on Haldol 15. We are going to be gradually reducing it. One rule of thumb I like to do is like, once we're about a third of the way to the level we want to get to, I'll probably make the first reduction in antipsychotic, the other antipsychotic. So at day 15, we're reducing to 10. And then we're thinking about sort of completely decreasing Haldol and discontinuing it by about 500 milligrams of clozapine. And you can always play this by ear based on how the patient's doing, but this is just, one way of thinking about it. Okay, the final concept to talk a little bit about here when thinking about non-response is the point of futility. So the point of futility was designed to help people think about the upper limit of antipsychotic plasma levels. And this is nicely described in Jonathan Meyer's book, The Clinical Use of Antipsychotic Plasma Levels. We know that there is a small proportion of patients who may never exhibit dose limiting adverse effects. They can continue to tolerate going up on the dose. However, the point of futility is typically considered the amount of medication that in which you go over that, less than 5% of patients will respond to these higher levels. And the point of futility for clozapine is thought to be about 1,000. And in my clinical experience, I may have 1 or 2 patients who have a level of maybe 1,200 or so that really seem to need that elevated level in order to get the response, but it's very, very rare. And I think you also, when you're thinking about non-response, you just have to think about the percentage of people that may actually have a component of ultra-treatment resistant schizophrenia. And these are people who have a degree of clozapine resistance. Overall, this probably makes up between 12 to 20% of people with schizophrenia. And I think the best research guidance for what this is found in the TRIP guidelines. And they say that you meet criteria for TRS and you have a failure to respond to adequate clozapine treatment with a therapeutic level over an appropriate amount of time. There is some debate about how long to continue the clozapine for, but in this guideline, they recommend pursuing clozapine for at least a duration of 3 months following attainment of therapeutic plasma levels. Okay, and with that, just a couple of quick conclusions. In my experience, TDM is really, really helpful to monitor clozapine response during an initial titration. It can help to prevent giving too much or too little clozapine, and can also help guiding discontinuing other antipsychotics. And in our experience, the immunoassay has been very, very helpful to make real-time clinical decisions about how somebody's doing on the clozapine. And you can always retitrate if you need to, or you can back down the dose or increase the dose based on that rapidly returning level. Okay, and with that, why don't we take some questions?
Excellent. If there are any questions today for Dr. Cotes, if they'll be posted in the webinar chat. I don't see anything immediately. I want to give the participants a moment if they have some thoughts. I really appreciate, Rob, that you went over the SMI advisor dosing tool. I think that's going to be an excellent tool for providers to be able to utilize to look at dosing according to their levels.
Yeah, so one of the questions that came up was the intra-patient variability in terms of the clozapine levels. And, it's been shown that in general, the coefficient of variance for clozapine levels is sort of around 30%. And, it may be better for some assays. Saladex would probably have a better answer than that than I would, but I tend to think about a coefficient of variance for clozapine around 30%. So if somebody is doing all the same things, taking the medication at the same time, no changes to the routine, you have a trough, it's 12 hours after the PM dose, it's not anything about, an AM dose that's in there, you can still see a 30% coefficient of variance. And, I think patients and parents call me all the time wondering about, changes to their clozapine level, and it can often be helpful to explain that there is some expected variation that you're going to be seeing.
There is a question about how to monitor the point of futility if TDM for clozapine is unavailable. Any thoughts on?
Yeah, I think it can be challenging, especially if you're sort of getting to a higher dose of clozapine and you don't have a level, and there are some risks of having a level above 1,000. So, if TDM is not available, you really have to kind of look at tolerability. You have to look at what the dose, what the kind of predicted level would be at a certain dose, especially as you're getting up to, high numbers of milligrams with clozapine, like 800 or 900 milligrams. At that point, I would start wondering kind of what's the level? Are we getting a little too hot here? But I think it can be really tough, and you have to kind of, I would say, like, use sort of some predictive models and then always take into account how the patient's doing and sort of tolerability.
Any quick data then on coffee and clozapine or no clozapine levels? Probably more related to caffeine.
Yeah, so, caffeine is a substrate of CYP1A2, and it can act, it can act like an inhibitor and increase clozapine levels maybe a little bit for people who drink a lot of caffeine. I've seen maybe about a 10% increase, for 10 to 15% increase for people who drink a lot of caffeine. So it's always something that you want to check in with people about, especially has their caffeine use changed. I usually recommend people drinking some caffeine, especially in the AM, if people need to get up and work and, they have stuff to do. It can kind of help with the sedation a little bit.
I'm going to try to give us maybe one or two more, but any thoughts on the benefits of incorporating ethnicity into the SMI advisor tool? Certain ethnicities have a higher rate of BEN, and wondered about getting levels contributing to managing that.
Yeah, great question about ethnicity. And, Jose De Leon and others have done a lot of very important work on understanding a little bit more about the ethnopsychopharmacology of clozapine. And I was thinking a little bit about incorporating some of that into the titration. There's a great paper that goes over 6 ancestry-based titrations for clozapine based on metabolism status and DNA ancestry. Clearly, patients who have a DNA ancestry from Asia appear to need less clozapine, and you have to be, I think, more cautious with the clozapine titration. So I think that there's a lot more work to be done in that area. The SMI advisor calculator is based on a reference that was published back in 2014 by, I think it's Rostami Hajemi. And there have been some newer pharmacokinetic, population pharmacokinetic models that have been available that we would love to implement. And then the other thing to know is that there's not probably a relationship between sort of increasing clozapine dose and the development of neutropenia. It's more of an idiosyncratic reaction that occurs, early during a clozapine titration. It's probably not a dose-dependent phenomenon.
Excellent. So I want to keep us on time. I've gotten the rest of the questions, so I'm hoping we can facilitate a way maybe to get those answered after the presentation's over. We could get them posted somewhere as well. But I want to thank everyone for their time today, for Saladex for sponsoring, and for Dr. Cotes to give us his lunch hour. Thank you so much.